All right, good evening, everyone. Thank you for being here. We're going to get started with our May meeting of the Pitt County Board of Health. And I'll call this meeting to order at 6 o'clock p.m. Before we approve the agenda, there are two changes I'd like to ask for. First is to add in an opportunity for public comment, and then also to move Dr. Mark Moss up, his presentation up to right above the child fatality report. And if no one has any objections to that, I would like to ask for a motion to approve the agenda with those changes. Right under the call to order. Thank you for asking. Did I get a motion for approval?
So moved.
Okay, and a second. Thank you so much. Is there any discussion about that? All those in favor of approving the agenda with those changes, please indicate by saying aye.
Aye.
Any opposed? Excellent. Thank you. Okay, are there any public comments for us to consider this evening? Okay, hearing none. Wonderful. Thank you. We will ask for Dr. Mark Moss. Hello, Dr. Moss.
So thank you for giving me time here. I'll try to keep it close to the allotted time. My name is Mark Moss. I am a resident of Greenville. I live on Rondo, and I'm also on the faculty here at ECU School of Dental Medicine. And we've been here, my wife and I have been here 7 years. I want to disclose that I'm a member of the American Dental Association's National Fluoridation Advisory Committee, and many of the slides and things that I have from other people, and I do want to acknowledge that and my students at ECU. Just want to try to give a brief overview of what we know about fluoridation and safety today, and help you all think about it in the best manner. We can look up our level of fluoride at the CDC website by looking under this My Water's Fluoride webpage. In North Carolina, about 88% of the public water supplies have fluoridation and optimal levels of fluoride. The goal for Healthy People 2030 nationally is 77%. On this webpage, you can look down and find Pitt County, and it lists what the water fluoride levels in the water, and whether they artificially fluoridate or not in each water supply. This little picture of 1 part per million shows how little the amount of fluoride is that goes into our drinking water. It's 0.7 milligrams per liter or parts per million, so it's less than 1 part per million. When we think about evidence, there's a hierarchy of research that is often used by scientists, and it's really based on the idea of randomization and can we control for bias that could arise from not randomizing. So this just kind of displays that the top of the pyramid are those studies that have systematically looked at clinical trials. Briefly, when we think about prevention, there's the bucket number 3, where we cover the whole community, and that's where community water fluoridation comes in. But there's also prevention in bucket number 1. When you go to a dental office, you might get a fluoride treatment. And then bucket number 2 is this idea of identifying high-risk places like school-based programs. So we can target a school as a public health intervention. There's been a lot of studies looking at fluoridation and whether it's effective or not. This is just a brief list of them. Side by side, here's 2 of them, and basically the evidence to support the benefits of fluoride with respect to preventing tooth decay are still very strong, and it seems to be better for primary teeth, so deciduous baby teeth, get a greater benefit than the permanent teeth. The most recent review just came out in October last year, and it still shows that even though the benefits of fluoridation are not as high as they once were, because a lot of people are using toothpaste now compared to when fluoridation first started, there's still benefits that go to children who are used in fluoridated communities. Other studies show that the benefit is true in the U.S. as well. And this is a study that was done using a national sample of children in the U.S., showed the benefits of community water fluoridation. The benefits are really highest in the low-income families. So that's what this graph shows, that as income level goes up, the difference between a fluoridated family and a non-fluoridated family gets smaller. So in high-income families, everyone's doing fine, whether they're fluoridated or not. But as income goes down, the gap between those exposed to fluoride and those not exposed to fluoride increases. So the benefits of fluoride are greater in low-income families. This was a study done in North Carolina looking at adolescents who had lifetime exposure to fluoride and what was their family level of education. So in the 100% fluoride group on the far right, the bars are fairly even. So family level of education was less than high school or greater than high school, and the risk of dental caries, tooth decay, was about even in the fluoridated communities. Whereas in the non-fluoridated communities, you see this gradient where lower education, more tooth decay. So the benefits of community water fluoridation really are the leveling of this social gradient that we see with respect to tooth decay. Costs are also affected by fluoridation. So communities that have more fluoride have lower costs associated with their Medicaid programs. This was what this study shows. Similarly, fewer children are going to the emergency room for dental treatment, or the operating room, sorry, not the emergency room, to the operating room for dental procedures if there's fluoridation in the community. So that's what this study shows. Costs attributable to fluoridation, basically it's $32 of averted treatment costs per person attributable to community water fluoridation. I hope you have these slides. I'm going through them pretty quick. So, this is a study that was comparing two studies. One stopped fluoridation and one kept it going. So these are both in Alberta, Canada. One is Calgary and one was Edmonton. So Calgary stopped their fluoride, and the prevalence of tooth decay got worse in that community, whereas in Edmonton, where they kept fluoride, it stayed about the same. So when communities stop fluoride, there's a cost in terms of children's tooth decay. When we think about safety, okay, so now we're flipping toward is fluoride safe? Is community water fluoridation safe? So starting around 2012, this idea that community water, or that fluoride caused decreases in IQ was first kind of promoted as something to look at. And since 2012, more people have been looking at that. And in fact, it's in the news all the time. Back in, let's see, when did this come out? Last August, a year ago, the National Toxicology Program released this report, which was highly publicized. And this is the same report. But what they showed was there's a need for more animal studies. So they're toxicologists. So they're kind of creating this research agenda. What do we need to know? So they would like to see some more animal studies to look at the toxic effects, whether they're there or not. What we have is inadequate, they determined. the mechanism is not clear. If there is a role for fluoride in IQ, we don't really understand it based on the study, the literature that we have. And with moderate confidence, the review found that communities that had, well, and this is like international data. So many of these studies were done in countries other than the U.S. High levels of fluoride were associated with lower child IQ. And this monograph at the bottom said, you know, levels that we're exposed to in the U.S. aren't really part of this report. So it's hard to make a comment about that. Back in February of this year, there was a report in JAMA Pediatrics that basically was built on the same NTP report, looking at the studies, and this got a lot of press. The review, and this is the conclusion from it, that it found that above, so if our levels of fluoride in the U.S. are optimally 0.7 milligrams per liter. It says levels above 1.5 milligrams per liter, which are twice as high, definitely look like there's something going on with IQ. That higher fluoride is lower IQ in children. However, it wasn't clear about levels below 1.5 milligrams per liter, which is what we're exposed to. A lot of people have raised concern about the analysis that was done. Most of the studies come from other countries, many of them from China, and the results are kind of all over the board. So this slide shows that this beta column, the first row, Canada minus 1.95, that is a negative effect on child IQ, but the confidence interval includes 0. So it's got a negative sign, minus 5.19 to plus 1.28. So the confidence interval suggests that there's a lot of variability, and if you were being real picky, you would say there's no association there. But when you summarize all these studies together, it looks like there's something going on. At the same, when that journal article came out, there were 2 editorials, and one here highlighted the need to be cautious in interpreting these results. They felt that the way the study was done was not appropriate, and many of the studies are not really good studies and should not be generalized. Just today, 2 more letters to the editor were published online related to this paper. So this, I had to put this slide together today. Again, they're raising concerns that this meta-analysis, a systematic review that shows a negative effect in children might not be done the way we want it done, that there's a need for a closer look. So to summarize, the adverse effects at the levels that we are exposed to are probably not there. Many of the studies are looked at are low-quality studies, and there's really no mechanism to explain how fluoride from drinking water would affect child IQ prenatal exposure. You know, we do know that the main exposure to fluoride comes from ingestion, from water, and there are other sources, but water is the main source in the U.S. The biggest concern is fluorosis. So if you get too much fluoride during tooth development, the teeth get stained, and that was kind of how they identified this as an issue way back in the 1900s. So fluorosis is clearly something that we need to be aware of, and it happens because children swallow toothpaste. The biggest source of fluoride from that's attributable to fluorosis comes from swallowing toothpaste. So we are, as dentists, we're clear to try to tell parents only a smear or a grain of rice size amount under age 3. Between ages 3 and 6, it's okay to use a pea size amount. Bone, I bring this one up because back in like 1990, 94, somewhere in there, 91, the National Toxicology Program suggested there was an association between fluoride and osteosarcoma. And this generated a lot of concern, and a lot of scientists got involved to explore that. But today, we feel pretty clear that fluoride does not cause osteosarcoma or bone fractures. So when we think about the neurodevelopment and IQ, there are other studies that weren't included in the meta-analysis, primarily because the inclusion criteria weren't met. But there's good evidence to suggest that some of these studies should be used and could contribute to showing that there is a measure of safety attributable to community water fluoridation that wasn't observed in the studies used in the National Toxicology Report. We did a look at studies that had levels of exposure that are like the U.S. and did an analysis of those studies. There were 28 publications that we looked at. 5 of them had levels of urinary fluoride as a marker. We used standardized mean difference and regression coefficients to look at this. When we looked at areas where fluoride levels are quite high compared to a lower level, we did see this pattern that the National Toxicology Report saw. But when we look at levels that are more like the U.S. and compare that to a lower level, we don't see an effect on child IQ. So that's an important piece of the puzzle. That are the levels that we're exposed to causing problems? Should we be worried about that? So this is another slide just summarizing that older studies that were done in China and other parts of the world kind of are showing a risk, but the more recent studies don't seem to show that same pattern. I'm not going to take too much time. When we look at urinary levels in the study, there's a lot of variability too in that. They looked at child's urine and their child's IQ. They found no association between fluoride in urine in children and child IQ. When they looked at maternal levels, prenatal levels, they found only this one study done in Mexico where salt is the way that fluoride is given. So in Mexico City, they don't have community water fluoridation, they have salt fluoridation. And in that study, higher levels of salt intake had higher levels of fluoride, and those were associated with a lower child IQ. If we take that study out, we don't see a strong pattern at all between fluoride and child IQ. So these are just some summary slides that, fluoride's been around for a long time. It's present everywhere. Back in 1901, this is an example of picture of fluorosis. They saw this pattern and they tried to understand where is this coming from. They also found that higher levels of fluoride caused fluorosis, but less tooth decay. So they tried to find this optimal level, that's what that red circle shows, where fluorosis goes down and caries goes down, and fluorosis is also not present. They looked at a lot of studies, a lot of different communities to identify that safe level. So that's that. This again shows originally they found that big difference between socioeconomic status and the benefits of community water fluoridation. North Carolina still, the Dental Society strongly supports it still. And there are other people that are saying there's a lack of evidence to support cessation. So winding down, thank you for your time. Overall, there's a benefit to tooth decay, that we prevent a lot of tooth decay from fluoride. We know that. We save money by adding fluoride to our drinking water. If we stop, those costs are going to go up. And the concerns about the risks in child IQ are kind of based on studies that aren't that good, and we need more research to sort that out. I'm going to stop.
Thank you, Dr. Moss. Appreciate that. Does anybody have any questions? I have a couple, but I'm going to defer to you guys first. Any questions? All right. So, thank you for that. That was great information. What is the typical level? Again, I think I heard you mention it along the way, but I want you to restate it. What's the typical level of fluoridation that we see in our community and maybe across the state?
Sure. So the optimal level is 0.7 milligrams per liter, 0.7, less than 1. And water operators are very good at getting that at that level. So, and every day, water systems are checked to make sure that that's not too much above or not too much below. So it's highly engineered.
Okay, thank you. And what are you hearing around the rest of the state about communities' appetite for banning fluoridation in their
Well, we live in a democracy, and our RFK Jr. has been articulating concerns. So it's a hot topic. A lot of communities are talking about this, and I'm not. I don't know how they go one way or the other, but I know it's under discussion.
Thank you.
I have a question.
Yes.
Do you think that this should be addressed here in our county? More so, I mean, to inform our community and promote it? What do you think?
Thank you. I think it's important to talk about it. I think, the news raises concerns, but at this point, my concern is that we're going to have a lot more tooth decay. We know that will happen. And so it's a little too early, I think, to make a decision about stopping community water fluoridation. That's my position.
Dr. Garrison.
I just wanted to play with the microphone first, but Dr. Moss, thank you for that. Two questions. One is, you on one of your first slides, it showed that Bell Author did not fluorinate their water supply, I think, and I was curious if you knew why that was.
Nope, I don't know why.
Do you know why? Why that is?
Some of these systems could be very small. I mean, and no, I don't know.
And then I think it'd be hard. I mean, you could show an association between fluoridation and IQ epidemiologically, but it'd be really hard because you don't really know the doses and the exposure that the children are getting. And you mentioned that there need to be more animal studies where they could really control the dose and then look at the outcomes of that. It seems like those would have been done, or are they being done, or what are they doing, and what's the status of all that?
So I'm a public health epidemiologist and don't know the toxicology, but based on that report, it suggests that the ones that have been done didn't show anything, and that if there is a way to do more, they're going to do it. Yeah, but I think you're right. Animal models are very important for toxicology.
Thank you.
Any other questions for Dr. Moss? Yes, Wes.
Just one question. Thank you very much for coming and presenting, because I think, other communities we've seen groups kind of come and give a lot of that information and present one side, and it's good to just have, some information about it. And I think Union County we've seen in North Carolina, Lincoln County, I think it was more of a cost of a system, and that's why they didn't renew over there. And then I think Harnett County's been discussing it. But have you seen, I think maybe you said Canada had some instances of, did you see a community where they stopped it and then carries went up?
So
in somewhere?
it takes like 7 years is what they estimate for you to see a difference. So, tooth decay doesn't happen that fast. And of course, there's other factors too. We shouldn't just think that fluoride's the only answer. Sugar consumption, that's a big one. Having a dry mouth, if you have, many asthma medications dry out your mouth. So tooth decay comes from a lot of different venues. And the fluoride is just to try to protect the enamel, to make it a little stronger when there's an acid attack. So these acids still come, but the fluoride helps the enamel be stronger and it resists the breakdown of the enamel. So in terms of cessation, if we stopped it, we probably wouldn't see any difference until, 5 or 7 years. So that's a problem. I know Utah, people are talking about Utah because Utah voted to stop. And, the challenge with Utah was that most of the rural communities don't have fluoride and the urban ones do. The urban ones have a higher socioeconomic status, so they're probably getting a toothbrush in the kid's mouth every night, whereas low-income families, that's a challenge. So, even Utah might not be a good case study because it's hard to compare apples to apples.
Thank you. Great information. Any other questions for Dr. Moss? Dr.
No.
Moss, thank you. Appreciate that.
I appreciate you. Thank you for all you do.
Thank you. All righty, next up, our child fatality report. Is it Vashti? Yes, okay.
Good evening.
Good evening.
I am Vashti. I'm the coordinator of our Women's and Children's Health Education Programs, and I am here to present our yearly update for our child fatality prevention team. So just to give a little background, of course, the child fatality system was established in 1991, and it operated through a 3-tier process. The first level was the North Carolina Child Fatality Task Force, which was established in 1991. On the second level was the North Carolina Child Fatality Prevention Team. That was established in 1992. And then the local Child Fatality Prevention Team was established in 1993. And each county has its own Child Fatality Prevention Team and also Community Child Protection Team. So each team has expectations, of course. We have to conduct our child fatality reviews. All child deaths come through to us first to review. We have to identify any gaps or deficiencies, whether through systems, through organizations, and then make recommendations and then implement those recommendations for changes. And lastly is to educate the community on how to prevent child deaths. One of the biggest changes that has recently occurred was in 2023, there was a new law that was set in place to actually strengthen the state's child fatality system. And with this change, one of the biggest changes was that now it is mandatory reporting that has to go into this new case reporting system. It still operates under the Division of Public Health. And again, the main thing behind this was to strengthen the child fatality prevention system. We also got additional support funding to be able to, whether it was reporting, identifying staff to help this transition. And then the last change was that the CCPT, child fatality, and DSS's CCPT now operates as a combined team. So the new language now is it being called the local team. So again, with these changes, data is mandatory reporting now. that actually begins in July of 2025. A lot of changes have been happening this year started in 2024. So there's a lot of transition, a lot of implementation changes that have been taking place. We're still doing a lot of trainings. One of the biggest trainings would take place actually May 16th and May 29th, so they can train myself and others on this new reporting system. So again, the magic date is July 1st, 2025. So the local team reviews child deaths according to the new law, meeting twice per year, different than previously we were meeting 4 times a year. But we also have the option of meeting additionally as scheduled if needed. So these reviews include child deaths of Pitt County for children under the age of 18. The difference now is that before we were reviewing all deaths, now the deaths that we review actually has to be one of these categories: undetermined causes, violence, sudden unexpected infant death, unintentional injury, suicide, motor vehicle incidents, deaths not expected in the next 6 months, deaths related to child maltreatment, or child deaths involving a child or child's family who was reported or known to been part of Child Protective Services. So our local team is appointed. These representatives represent public agencies, non-public agencies, and the community. We have our health director, representatives also from the health department, DSS director, staff from DSS, local law enforcement, someone from the DA's office, local member of health professionals, community action agency, schools, guardian ad litem, EMS, firefighter, district county judge. We have 2 county medical examiners. We actually have new on board, our old one retired, a representative from local child care or Head Start program, and also a parent of a child who died before 18th birthday. Our team is not fully staffed right now. We're still looking for some of these, and that's going to be our project for the next year, to get our team fully staffed. As far as leadership, our health director, Wes Gray, is acting as the chair. I am the co-chair, and our review coordinator is vacant right now. So I'm actually doing the 2 roles. So with our review, we have access to birth and death certificates, medical facilities, information from the Department of Social Services, information from the courts, law enforcement agencies, the school system, and any outcomes of services and circumstances surrounding the child's death. Again, the main goal of the team is to review child deaths and study ways to prevent future child fatalities. Again, we have to identify deficiencies in the delivery of services to children and families by the public agencies, make and carry out any changes that can prevent future deaths, promote understanding of the causes of child deaths, and then advocate for children through education. So in 2023, as far as our reviews, there were actually 31 child deaths in our county, in Pitt County. Our subcommittee chose to review 7 of those because the remaining were basically related to prematurity and or birth defects. And the causes of death for those were unsafe sleep, suicide by firearm, unsafe crossing, motor vehicle accidents, drug overdose, SID, sudden infant death syndrome, and then violence as a result of firearms. So when we review actions and things that are happening in our county around these categories, we still have our Safe Sleep program where we distribute cribs to the community for just $10. They're very high quality pack and plays. We provide education, and we're starting to take our program out into the community versus them coming into the agency. As far as gun locks distribution and safe storage programs, the Department of Social Services have a distribution program. ECU Firearm Safety Coalition and also East Carolina Injury Prevention Programs have programs that they're doing around gun locks and storage safety. Also, East Carolina Injury Prevention Program, Greenville Police Department, Pitt County Sheriff's Office also have programs that target violence and gang prevention. When our team met, some of the recommendations were the need for more anti-bullying education and programs, and particularly in the school system. We talked about the importance of prenatal and newborn education around smoking, et cetera. There was a lot of conversation around the education of our community, particularly parents and caregivers understanding when newborns or children need to go to the hospital versus keeping them home. And then also the recommendation for more school community trainings around firearms and suicide. One of the actions that's currently been implemented is our fatality team is collaborating with the Children's Hospital, the Family Wellness in Pitt County. On June the 2nd, June the 2nd is, I think it's Firearms Awareness Day, so we're hosting a mini conference where we have some speakers from Prevent Child Abuse who's going to be coming from 8:15 to 12:15. So we're looking forward to that mini training. All of you are invited. Are there any questions?
Any questions? Yes.
I was curious why we were reviewing 23 data when we're in 25. Is it lag because of medical examiner or?
Exactly. Like this is 2025, and so we're actually reviewing cases from 2024 now.
I got you.
So it's going to be a year behind. And one of the things too, because some of the cases may be involved in the court, so we have to wait until everything kind of settles before we even review. So they're kind of a year behind. We're doing 2024 deaths now.
Thanks.
Commissioner?
Thank you. Thank you for the report. What are some of the gaps, and you mentioned the gaps?
Our county's doing a lot. We are doing a whole lot when we look at the different categories when it comes to sudden infant death syndrome, firearm safety, gun violence. As you saw, we have a lot of organizations that are doing a lot of work. When it comes to the majority of our child deaths, a lot of that is around prenatal, preconception. As you saw, only 7 of those that were reviewed of all the cases that we got. The other ones were related to prenatal birth defects and things like that. So there's a lot of education that needs to be done when it comes to preconception, educating women before they get pregnant, making sure they're keeping prenatal appointments, doing family history to see if there's risk and things like that. But our county's doing a lot, really, when it comes to work programs and things.
Thank you so much for all of the great information. Just wanted to know if any of those positions for your local team are hard to fill positions, that you might want to say something about those professions so that they can hear that they're needed. It was like the third slide.
Yes,
Okay.
thank you. We really need to fill these positions right now. We are needing a representative from the Community Action Agency. We're going to be reaching out to the school system. We have new leadership there, so we're going to reach out to see if we get representation from there. We need someone from Guardian ad litem. And then also a representative from a child care or Head Start program. And it's always been hard to find a parent of a child who died before 18th birthday.
Thank you.
Yes, it's virtual, so they don't have to leave the office. And as prior, we were meeting 4 times a year. Now the requirement is only 2 times a year, starting July. So unless our cases really increase, it'll be twice a year, unless we see the need.
Dr. Garrison?
It seemed like the number was low for Pitt County. How do we compare do y'all look at other counties to see sort of per capita distribution and things like that?
What do you mean, as far as funding
Or number of cases and causes and things like that?
No. Probably should, and I will. I'm still kind of new in this position, still trying to get my footing, but that is definitely something.
Yeah, that might help answer the question, how are we doing relative to how how everybody else is doing.
Yes.
Because does every county or every health district have a child fatality task force? I would think they probably do.
Every county has their own team. Some, depending on how small they are, can combine with another county.
Thanks.
You're welcome.
I did have one really quick question. As you're working through your programming and developing your programming, do you guys seek the input of children that might be impacted by that programming? So for your middle schoolers and your high schoolers, do you guys test any of that programming or that material on those groups to get feedback from them before rolling it out?
You mean like when you say programming, for example?
So you said that there was programming you guys were developing to address the causes of those deaths. So let's say suicide prevention. Do we seek the input from some of these children, not necessarily the ones that, may have attempted and failed, but just to get some feedback from kids in that age group to figure out what's in their heads?
That's a wonderful idea. And I'm thinking maybe some of the other organizations. I know Pitt County's SAD has, I don't know if it's the operating SAD program, but also the another program. They actually utilize young people on their committee to get feedback from them as far as what other kids need. I can't think of they meet on Wednesdays. Shaq, thank you, West. The School Health Advisory Council. They do have young people that serve on that committee where they get feedback from the young people.
Thank you. Any other questions? Vashti, thank you so much.
Thank y'all.
Excellent presentation. Thank you. Why don't you go ahead and press and let us know what happens? All right. Next on our agenda, we have to corral Dr. Garrison. We have a few items for us to vote on. So, Wes, we're going to turn it over to you for the budget.
Absolutely. Appreciate it. Thank you. And we presented a version of this last month, our request. Since then, we've got the recommended county budget. And last Tuesday, I presented this to the Board of County Commissioners as their workshop for their consideration. So nothing has been voted on there. Pending any decisions and changes, hopefully the timeline is June, the first week of June, or before the end of June for the county to finally to decide the county's recommended budget. But this is our public health request for your consideration. So the fiscal year 25-26 budget summary, we're going to focus on growth and enhancing current services, increasing child health programming, primary care, dental services, maintain appropriate staffing levels in all divisions. And it's a non-expansion year. It's a no-growth year for all departments in the county. So that's what we're looking at this year. So positive on the side of maintaining services, expanding services, and staff, but to be on the lookout for any potential federal changes just because of the environment we've been living in the last few months. Again, no programs are changing. We're keeping the exact same programs in personal health, outreach, health education, health promotions, environmental health, WIC nutrition, and other services. So I've also added since last year, I guess, the opioid settlement into that portfolio for other services. So the fiscal year 25-26 budget, our request was $16,111,634. The recommended budget this year is $16,031,131. And the main difference is we did trim a few areas in the budget to allow for us to make one request for a full-time employee for a advanced practice provider, but we were not able to get that position in this budget. So that's why we see that little bit of a reduction from the request to the recommended. The manager's budget also adds in a 3% cost of living adjustment for all staff on top of the our request, and then no health insurance increases. So this is our 32 programs. This is how we're spread out over across revenues, administration on down to diabetes recognition, including environmental health, WIC, all of our programs, but but spread out over what revenues come in to provide for each one. So you can see $1.7 million in projected Medicaid revenues, and that's spread over administration, adult health, communicable disease, and our clinical programs, and then the mobile dental unit. A little bit of Medicare coming in. Our cost settlement is our MedMax funds, so administration, communicable disease, maternal health, family planning, mobile dental, about $700,000 anticipated cost settlement. Some third-party insurance, that's private insurance, estimated conservatively about $98,500 spread over adult health, definitely in communicable disease, family planning, maternal care coordination. You can see DHHS funding, and I'll show the breakdown later in the presentation about how much of our budget is funding from DHHS, which is a combination of legislative appropriated funds from the state, but the main part is our federal pass-through dollars from block grants from the CDC and from the federal government coming into the state and then getting pushed back to us through agreement addendas. That's $4.1 million. Fees, mainly for environmental health services and a few clinical services, but $274,000 in fees. Other, which is our grants and our donations or things like that, $212,511. The general fund from the county is $3.2 million, and then from our fund balance portion of that $15 million fund balance we have is $5.6 to balance the budget to make it $16,031,131. So what's different now is we've gone down in the amount of general fund dollars we're using, and we're using more of our own dollars from the fund balance to balance that budget. And hopefully that will continue, and as more dollars come in, say from cost settlement, that will go into our fund balance, and we'll be able to use that every year instead of asking for increased county dollars. So the revenue picture, if you start to look at the very top, that blue pie, and then go right, $1.7 million, that's 11% of the budget, that's Medicaid. A little bit of Medicare, less than 1%. Cost settlements, 4%. Private third-party payers, 1%. DHHS funding, that's state and federal, compromises about a quarter of our budget, 26%. Fees, only 2%. There's no changes in fee recommendations this year. Other is about 1%. County general fund, local appropriations, 20%, and appropriation from fund balance is 35%. So a little bit update on the payer mix. So the last available numbers we have from the state on all the state's payer mixes was from the 23-24 fiscal year. You can see I've just shown the top 30 health departments in terms of total ranked by total patients. So there's Pitt County. About 29% of our patients are Medicaid. About 53% of our patients are self-pay. And you can see, look up there at Durham County, about 80% of their patients are self-pay. They do a lot of free services. You can see that goes up and down. But we anticipate with the increase in Medicaid coverage for citizens, we'll see our 20% go up. So that means the patients we do see will have insurance that we can bill and maximize reimbursements from that. And we'll see that self-pay number decrease, or it should decrease. So a closer look at DHHS funding. We have 24 agreement addendas this year, contracts from the state. These are federal pass-through and state dollar combinations. Then we have our contracts, that's minority diabetes, and then our grants, which could be anything from community health grants, telehealth, a triple P is in the form of a grant. So you can look at what grants are 100% funded by DHHS funding, and then which ones are zero. And I've kind of ranked them in order of, so our minority diabetes program for the 9 counties that we serve as the fiscal agent for here in Region 10, that's 100% funded by a grant, or DHHS. And then the amount Pitt gets from that is 100% funded. Project Assist, that's our tobacco funding from the CDC, and I'll talk a little bit more about that later. But that's 100% funded, and that sponsors our regional coordinator for tobacco. Then you can see going on down a little bit in percentage, and WIC, our Nurse Family Partnership, Healthy Start, Food and Lodging, Breastfeeding, BSEP, Family Planning, Child Health, TB, Vector Control. And then you see the program, and then look at environmental health. That's about 2% funded by state and federal dollars. The rest is our local dollars and our fees for that. And then our Pit Stop, Smart Start, Adult Health, Infant Mortality, Maternity Care Coordination, Mobile Dental, Diabetes Recognition Program. There's no state, federal dollars for any of those. Those all have to be locally supported dollars or revenue generating dollars to support those programs. Just delving into just one program, so look at communicable disease. That's a $1.6 million program. That's what it costs to run that. Medicaid covers about 70%, less than 1% Medicare. Medmax, about 2%, cost settlement, 5% private. DHHS only covers 11% of our communicable disease funding. Fees, 2%, other less than 1%, general fund less than 1%, 73% we fund in through our fund balance. I'll cover this during the legislative update, but we've asked the legislature for $25 million additional dollars for communicable disease to be supporting public health programs, and we present numbers like this to the legislature to show how much is local and how much each dollar contributed to this prevents communicable disease and best return on investment. But just to show you, only 11% through about 4 AAs covers our communicable disease program. It's a pretty costly program, but saves a lot of money for the county. TB, that's $288,000 total. DHHS covers about 18% of that. I want to mention this one because the funding formula for TB has not changed in a very long time. We get about $41,000 from the state for that program. And what they're looking at, they're going to propose at the health directors meeting tomorrow a change in that formula. And we saw a little bit last year, but we kind of pushed that down and punted it another year. But they're looking at presenting some formulas tomorrow to us to show pretty big cuts for the counties that have little to no TB, which is most of our eastern counties, and reallocating a lot of those funds to Mecklenburg and Wake, where we're seeing a little bit more TB. And so it's going to, any way they come up with a formula, we'll probably see likely cuts. The worst would probably be about a $19,000 cut. So we go from $41,000 to a little over $29,000. So, but Halifax is looking at 100% of their funding getting cut. $83,000 is what they have gotten because they had some high cases in the early 90s. They had a higher amount coming in every year. They're looking at a huge cut to their TB program. So it's not going to affect us to that amount, but statewide, that's going to be a pretty big turmoil in the TB program. That's just one example. And then looking at our expenses, you can see 77% of our expenses of that $16 million is going to salary and fringe, 8% to our operations, 3% to our MIS contract in the county, and then 12% to our contracts. I see there are contract employees, dental, our nurse practitioners, so all the contracts we have for contract staff, and then other agencies that we contract with comprise about 12% of the budget. So some of the issues I'll mention that we're looking for is AA 451, that's the Tobacco Prevention and Control AA. CDC tobacco funds, that's always been, since the early 90s, we've gotten these in 5-year cycles. What we found out a few weeks ago that we did not get the state did not get the 5th year of a 5-year tobacco grant. They got a no-cost extension but did not get the 5th year. So what does that mean? They said, well, how do we fund the last year of this 5th year, much less going forward? So what we still have a little bit of time left in this year, which should be fine. We've worked that out to keep that regional coordinator from having to be furloughed. But the next year is what we were real worried about. So the state is using dual settlement dollars to cover us for fiscal year 25-26. So we shouldn't see any cuts there. We don't know if that's a long-term option, if they can do that every year with that JUUL money. But that means that coordinator can only talk about vaping and JUUL products. They can't really talk about cigars or pipes or tobacco or anything like that. It's got to be whatever the settlement for the JUUL funds can be. So there's going to be a little restriction on what that employee can do, but we at least have that for one more year. And we'll see how that, if the CD funds get restored or if JUUL can take over for that. And then the other one is kind of more recent. Last Thursday, I think, we got an email from the state. It's the Breastfeeding Peer Counseling, AA 415. The USDA has not yet awarded funding for activities for October of this year to May 31st of next year. So DHH has adjusted our AA to cover June 1st through September 30th. And so that was sent out yesterday. And we get an update tomorrow from the WIC program at the state to let us know a little bit more about that situation. But that's a pretty new development. Fiscal year 25-26 goals. Again, as I said, as more of our clients are on Medicaid, we want to maximize the revenues we can get from those services provided to Medicaid patients. Continue to seek grant funding, spend down federal and state dollars, maintain low staff turnover and vacancy rates. Work with lawmakers on programs and funding streams. We want to educate them on how CD is funded, the benefits of communicable disease funding. We want to preserve that TB funding for fiscal year 26-27. Strengthen that data collection activity reports, and then prevent and treat all communicable diseases, provide quality environmental health services, and respond to community needs with new or adjusted services. And with that, I'll end and take any questions y'all might have.
Wes, did you say that what replenishes that fund balance? Unexpected over or
Yeah,
new
so
funding from
mostly
DHHS?
it would be our cost settlement. Say if dental cost settlement came in and every year was higher and higher, we could literally see, adding to that fund balance and not having to use that fund balance part. We're using so much kind of fund balance that's likely we will have to dip into some of that, but anticipated if we can maximize the cost settlement dollars coming in, that's where we're going to see those gains every year and maximize how much we're doing third-party billing and maximizing what we can get from Medicaid.
I guess my question more specifically would be if we're using $5 million fund balance and that is $15 million in that balance, without a change in the future, that's only 3 years of
Right.
a big chunk of the budget. And so is there anticipated that $5 million is going to be matched with some additional revenue stream, or will it continue to dwindle down?
Right, and this year, Angie will go over it later, but we kind of had about a $6 million local appropriation, $3 million fund balance to cover the gap. So we've not even finished the local appropriation. Hope we don't use that and we don't have to tap into this year's. So that $3 million that we put for the current year's budget, we hope we don't have to go into this time. So the hope is we don't have to use much of that $5 in this first year coming up. And then if that works out every year, if we add into it with cost settlement or revenue generating programs, that we could potentially stay flat, keep that county request low and use our own dollars, but not to drift down. The average county needs to have 8, but a lot of them have around 15 as a policy. We have about 100% of our fund balance to cover the whole year of budget. So I think this first year, seeing how we can do with this 5 and hopefully not using much of it, and then planning for the next year based on how we do. You want to say anything about that?
So in our discussions with finance, that has been, of course, when you see the number, you're like, ooh, that's coming out of the savings account. And like any good steward, we want to make sure that, we're not draining our own savings account. Fund balance comes from a combination of excess dollars that at the end of the year that have been put in the accounts that we have not spent. And so basically, and as you'll see, month to month, sometimes we're in the negative as a fund at the whole, and then the next month we might break even. So the county, it is kind of the county's way of making sure that, number one, we don't bring in excess revenues, let's say of over $500,000, $600,000, while the county is also funding us at 52%. So it's a balancing act. And I think realistically, it's a way to also kind of, for the county, as they have seen that we have increased our revenues, to kind of find that balancing point when they've had to also balance priorities with other departments and everything else. So we have currently right now over $15 million in fund balance. They do expect that fund balance number to grow at the end of the year. What that number will grow at, we don't get the final number till the audit is complete, but they do expect a growth in our fund balance. But the local government association, from an audit standpoint, does not necessarily like once you reach kind of a certain number. They do want you to start kind of expending it. So it's kind of this balancing act of got a little too much in savings, you need to start expending it. So it's a fine line that we're kind of walking, but it's a good line in the sense that we are more self-supportive now this year overall than we have been. They've allotted over $3.4 million in fund balance for this current budget year, and we have not had one deposit yet from fund balance into our FY25 fund. So we'll see exactly at the end of June where we exactly land with that when all revenues are taken in. But right now, I think to have allotted $3.4 million and to not have to have used it yet, we're doing pretty good. So, but it's a combination of all leftover county dollars, revenues. Medicaid is accounted for that kind of in a special pot in the fund balance, but our fund balance is held in the intergovernmental general fund.
Thank you. Lowell, yes.
I got to push the button.
Yeah.
It is
Oh,
kind
was
of
this not
fun.
on?
Yeah.
Okay, sorry.
No, I was just talking about the button. So we're the health department and we help people, and now
Yes.
it almost feels like we're becoming more. I mean, we got to be a business. I get it. We got to make money, but it almost feels like is this going to change how we? Is this going to change our focus to being more worried about what makes money as opposed to what helps the community? And I want to make sure it doesn't.
Yes, no, absolutely. Our focus is to maximize where we can maximize revenue, but never sacrifice access to care. And I think that is in every discussion that we have had for access to care, the number one question is, what is our plan for the uninsured? While we know that we can't take on an extra burden of, let's say, $3 million a year for uninsured cost, there are ways that we can work for access to care issues for the uninsured. And that is our number one goal. For us, for example, expanding credentialing with commercial insurances. We know when our back to school clinics are a perfect example. We do get a large demand for back to school immunizations, and a lot of those demands are from clients and people who have third party insurances. So that's an opportunity for us to maximize those revenues and reimbursements while we will work with people on the cost of immunizations and everything else. So no, it is not, we will never want to deny care based on someone's inability to pay. It is just an opportunity to maximize revenues. For example, the PHP value-based plans, we want to be able to make sure that our clinical flow services are taking advantage of those incentive payments. So if we've got a family planning patient who is an incentive payment may be that we make sure that she's had her family planning physical in the yearly. If there's an immunization that, let's say, she qualifies for that she is in need of that she doesn't have, and then maybe there's another checklist, that's an incentive payment that, let's say, United Healthcare, WellCare, or something may throw our way. We want to make sure that we're making sure that we maximize all opportunities for revenue.
Okay, so as we become more and more self-funding, are we giving up the opportunity to go and do something else that's not self? I mean, that's a losing. So I mean, there's the part of the mission is to go
Yes.
do this, and we say, well, we would do that. You know, as we grow our business, we would do that. But since we're growing the business, but we're taking away from this side, we're not going to move in.
I don't
I
think,
can't give you an
I
example.
don't think
You know
we're
what I'm trying
taking
to
away
ask?
from anybody.
Or not going to the next step.
Correct.
or
I don't think
moving
we're
up.
taking away from anybody because overall our funding is about the same. I think what we're doing is we're saying, okay, if let's say, I'm going to use environmental health just because I used to be in environmental health. We didn't do this. Let me preface this, we didn't do this. But let's say environmental health had an extra $65,000 at the end of the year in their budget that they did not use of operational funding. But let's say then we've got a clinical need where they wanted to start doing more adult care services. Then that's the time that we look at, okay, if this is operational funds that are not expended from this program, we want to expand services over here, then we move funding over here to here because for the past 3-year history, you've had this excess operational funds. So no, we're not sacrificing for one. If anything, I think we are looking at ways to maximize grant funding, maximize, like literally today we had a meeting about starting a new service and we've got a credit sitting over at a vendor and we're going to use that credit for the uninsured. I mean, that's the way that we're going about trying to make sure that we're maximizing our revenues. So, yes, substantially grow, but also not sink the ship at the same time that we're trying to grow. Yeah.
Okay. Wes?
I think most health departments too, when they are limited, we're blessed that we have a growing county, and but I think a lot of health departments are constrained and they cannot get any more like local dollars, so they do things like maximize revenue for Medicaid. They do things like add a dental program to subsidize environmental health and all their other programs. Just example, we had a home health program that lost about $400,000 a year. We could not go to the county for that. This was an MTW, so we used our dental revenues to protect that, to keep that going for 4 or 5 more years longer than we had revenues for it coming in from the county to provide that service. So I think it's a way to protect some programs that might be facing cuts or might not bring in any dollars. and to keep those. That's it's easier to do that on your own than to say go and ask the county for additional revenues for a program. It's better to say, hey, can we keep the revenues we generate every year and use that for our program than to go and ask for new dollars.
Thank you. Any other questions?
Do we have any state, federal, or grant funds that are at risk for reverting? Or they roll over year to year?
I don't see any that are reverting. The only thing that we had, like say for the tobacco one the other day, they said, do y'all have anything y'all need to spend the rest of the year? And we're like, yes, we do. We have our $19,000, so they asked us to just stop spending to the next month, for that. But no, they're not gone and said to pull any back. No. We've just heard in that one case, stop spending future dollars.
Good questions. Anyone else? Any questions? Okay, Wes, let's bring this home.
All right.
You want to give us a slide to look at so we know what that budget number is?
This
that
is
we're
the
voting on?
slide for our recommended budget, revenues match expenditures of, we did $16,031,131 is our proposal for y'all today.
Okay.
Move approval.
All right, it's been moved and properly seconded. Is there any discussion? Any other questions? Real good? Okay. All those in favor, please indicate by saying aye.
Aye.
Are there any opposals? Nothing? All right, very good, thank you.
All right, thank y'all. I think I'm up next too. Should be, I don't know if it's on your screen yet, but I'll pull up these so everybody can see that I've got 3 quick Board of Health policies. And I can quickly review them, and then we can do like we usually do and just vote on all 3 if that's okay with y'all. The first one is the exempt employees comp time. So no changes on this. We just provided it to fit the new template for the administrative policy review. So basically, the purpose was recognize exceptional limited situations where health department employees who are exempt from the overtime provisions of FLSA may be required to work significantly longer work hours or work weeks that normally are required. And this outlines the situation that might fall into, the process for that person earning comp time, and then what approvals they have to get. It's non-cumulative, it's non-transferable, and you can't get it when you leave or are separated. So does anybody have any questions about that? Second one, continuing education and skill building. So again, nothing new has changed from last year, just revised the new template. This is our policy to encourage skill development and aims to reimburse employees for a portion of the cost of textbooks and tuition whenever applicable. It has our policy, administrative and clerical staff due to very limited workshops and training schedules available to the employee group. The course must be approved by management. Requests must be made in writing. All classwork must be completed at a grade of A or B to receive reimbursement. Anybody have any questions about that one? Third is the administrative voluntary leave policy. Again, no changes, simply putting a new template. This health department encourages employees to be active in their community by volunteering. The department has established guidelines for employees to follow if they wish to volunteer. And it lists the policy and procedure for that request, including a description, the name of the organization, the total hours per week, the exact time they anticipate being out, anticipated duration, and then the reason such activity cannot be done outside of work hours, and then how it's evaluated and approved by the supervisor or the division head. All right. Any questions about that one or any of the other?
You guys okay if we take all 3 of these together? All right, wonderful. If I can have a motion to approve these 3 policies. Second, wonderful. So we have a motion and a second. Any discussion? All those in favor, please say aye.
Aye.
Any opposed? Awesome, thank you, Les. Okay, Angie, I think you're up next for our monthly financial report. Before you get started, because we've got a few items we got to go through, I promised Dr. McIntosh we would not be here 2 hours tonight. He made me promise him. So let's quickly go through these. I did not.
Oh, okay. I'm sorry. Okay, so we have your monthly report through the end of April, period 10. So this is all of our revenues received through period 10, closing. Currently, right now, your total revenues stand at $10,472,325. Your county appropriation of that is the 4.8 million of that. The right now, just so you know, the fund balance appropriated in our revenues for FY25 was approximately $3.4 million was appropriated out of fund balance, which we have zero to see deposited into our budget yet. I will say that out of cost settlement, which is our Medicaid maximization cost settlement and also our PHP direct payments, we budgeted a total of $703,000 total for the year. And I'm glad to say that as of this report, we collected a total of $661,502, which is roughly 94% of what we needed to collect, left a gap of $41,997. We did receive a check that covered that amount today. So we've met our budget for cost settlement, and 30 minutes before this meeting, I opened 3 envelopes, which are additional cost settlement dollars that are the 10% hold payments from previous years. So there will be additional dollars. So we've done really well with the cost settlement and exceeded the budget this year to date. Medicaid receipts, these are our billable Medicaid receipts. We budgeted a total of $1,485,870 total for the budget for this year. And I'm happy to report we've collected over 94% at the end of April. So we've collected $1,405,232, and that's at the end of April. That's not including anything that's come in this month to date. So we've got about $80,000 yet to collect. So we're doing really well as far as collections. Again, we've worked extensively, staff has, on correcting some things with our electronic health record and getting some additional staff in there. So that's done really well. So speaking of expenses, so you've got your expenses on the right-hand side as well. You'll still see that our salary and fringe personnel costs is still the number one majority of our expenses. Contractual expenses, our operating expenses for the total, when you look at a $16 million budget, our operating expenses to actual operate are a little over 1.3 million. We do run a lean budget. They do run, all the division directors and supervisors do a really good job of running a lean budget. The capital outlay in that far right column at the admin line, the $223,870, that is $74,000 in outlay of 2 vehicles, and then everything after $74,000 has been what we have spent on the Pitt Stop project, and that was allocated fund balance rolled over from last year from the commissioners. So your total expenses year to date are $11,345,717. You will see that we are currently at the deficit of $873,392. Aid to county is currently being calculated for revenue drawdown this week. So far, we're about over $260,000 so far calculated, and that will grow. So that is where we are at with that.
Any questions?
Any questions about this? Okay. I am glad to report we have in hand currently been awarded 3 grants. A $30,000 grant for dental access to care expansion from the North Carolina Alliances of Public Health Agencies. This will be used for expanding dental access to care services, primarily in the Pitt Stop for increased dental care. Nurse Family Partnership received their $15,000 grant award. This is from Women for Women. They did receive this grant last year. However, this is a larger increase in grant award. This award specifically goes to client support. The clients enrolled in their program can receive educational assistance from this, housing assistance, emergency assistance such as with their electrical bills, and emergency food assistance, and this will also provide some peer-to-peer group support as well. And so that's $15,000. And then we also received a very unexpected $9,000 Duke University award. This is a collaboration that Vashti Cottrell actually started over 2 years ago. There was no promise of any money or anything like that to work when Vashti was in her former role working with the youth. There's so many acronyms. It's a youth that focuses on well-being, sexual health, pregnancy prevention. Tiffany Thigpen is in that position now, and she continued that collaboration and role. And so Duke contacted us this week, and so we really appreciate your hard work with us for the last 2 years, and would you accept a $9,000 grant from us? So it was very unexpected. Tiffany is very thankful to have it, and so she has, we've completed the necessary paperwork and submitted that to Duke. So these are 3 grants that we've actually gotten in the last week or so. So again, trying to get in extra dollars. So that is all I have at this time.
Mike would love to hear a little bit about what they use that grant money for, maybe a
Okay,
quick report out.
absolutely,
Later.
absolutely.
Nice, thank you. We did. We did. We voted on the budget. Is that what you asked? On the, these are just for reports. This is just for report. We don't need to vote on the. I know it's been a while, Lowell. It's okay. Bless your heart. All right, Wes.
All right, I've got a quick legislative update. I'll just mention a few things. House Bill 430, that protecting children and families from nicotine and vaping, seems with the 4 Republican co-sponsors and the 21 co-sponsors, started out really great, but it seemed to hit a snag. It's stuck in the Rules Committee. It did not make the crossover deadline to go to be voted on to go to the Senate. So hopefully, maybe something can change on that. Maybe they could do some negotiating on the registry side of it, which is registering the vape shops. That seems to be the hurdle with the Rules Committee chair. I think they were willing to go along with the 21 for smoking and vaping, but they wanted to drop the regulatory piece, and that was a no-go for Ped Society and all the big sponsors of that bill. So they are likely going to push that probably till next year. I hope they can work something out on the 21 part, but I think they really want that registry. And I think that registry is very important just to know what's being sold in our communities. Next thing, CD funds, I mentioned earlier, $25 million. That did not get in the governor's budget, but again, they're doing conferences rest of the summer. We're doing a lot of local outreach to the appropriations chairs, and then especially the health chairs. Dr. Reeder is one of them, making sure that they know our concerns about getting that $25 million put in the budget. Community health grants, we're working on a letter, and we've got the draft of the letter, and we're sending that out after the health directors meeting this week to request that Office of Rural Health make a legislative change or request a legislative change to pull $2.5 million out of their $14 million budget to appropriate $50 per uninsured visit to local health departments to do primary care. The 42 health departments have signed on to that letter. That will require agreement from FQHCs, free clinics, and the Hospital Association, who also receive those grants, to say maybe they can carve that out. But our argument is you get 50,000 visits if you pay for $50 per visit across all those health departments. And the idea would be to draw that down each month from the state until that pot is exhausted every year. But at least we'll give the health departments some reimbursement for that. Like I said, a lot of these grants go to capacity building or like starting a program, or say a group gets $150,000 community health grant and then say their provider leaves in the middle of the year, or say they only see 4 or 5 patients a day or something like that. It's just kind of inefficient the way it works in some of these counties. So the hope is that if everybody can benefit, you'd see at least $50,000 and 50,000 uninsured visits a year with some kind of compensation. So we'll see how that goes with Office of Rural Health. The mobile tattoos did not make crossover, that bill, Kent. And then there's a lot of environmental health laws, and Kent Mike can speak some more to that. I don't know if you want to mention a few things, but there was a lot of changes in permitting, especially like perpetual permits. And then there's one other one. There was the minor consent changes. So the House fast-tracked a lot of changes to our minor consent bill, but it doesn't seem like the Senate is willing to take that up. So hopefully it stops where it stops. So a lot of these bills are, I won't even mention, but there's one for ivermectin use to allow state pharmacies to prescribe that. But a lot of these are House-generated bills, and then they're not going to be taken up by the Senate. So if they are, I'll mention those next month if we see a little clarity on some of those. But that's our legislative update, and I wanted to mention if any division directors here have anything pressing they want to speak about. All right. If not, I will move into my health director's report. All right, just a quick, we'll just say a respiratory virus update since we're out of respiratory virus season. Continue to see very low numbers of flu, COVID, RSV. 11 COVID inpatients across the ECU system, down from 18 last month. Clinic visits, definitely over the last 3 months, have seen big increases month to month. So we're at 976 clinic clients were seen in April, 1,172 scheduled. That's a show rate of 83%. Very good show rate. 8,414 clinical visits through the end of, should be April. And again, April, that month included Good Friday holiday and a no clinic day on April 4th. So 2 days were no clinic. We still had a lot of patients coming through. STD rapid clinics, you can see we're still seeing over the last few months increases in February, March, and April of clients coming in for those rapid clinic visits and treatment. Environmental health report, 190 site visits, sites evaluated about 84, 598 on-site consultative contacts, and then 19 operation permits issued. On the well side, well sites evaluated were 6, consultative visits 28. And I think there were 4 new issued well construction permits issued in April. Again, you can see how many our environmental health food and lodging staff have done. A very large amount of restaurant inspections. We're ramping up 19 pool inspections. A lot of staff have been doing those while we're searching for an employee to fill that role. A lot of consultative visits. And then, again, health education, vector control, and general sanitation numbers as well. WIC participation, that report came out today. Again, it's a few months behind every month, but we get our February 2025 number was 4,212 participation. Again, our baseline for the year is 4,143. So we have to maintain 97% of that, which is 4,019. We're at 4,212. The average for the year so far, all of our months combined was 4,310. So we're right now with 4,212 sitting at 104.02% of our target baseline. So doing very well in participation for WIC. Our dental update, this is our dental flyer. Dr. Askew's last day in the dental program. His contract's ended the 25th of April. We're currently working on a contract for a backup provider, but the numbers from January through March, I'll mention, we had 147 patients, all under 18. Visit types were 145 exams, 147 cleanings, 518 x-rays, 364 sealants, 141 fillings, and 4 extractions. 42 were referred out to other providers. The academic health department, I mentioned in the internship coordinator proposal. We've received that document from ECU Public Health, the grad school, and a similar document from the ECU College of Nursing. Internships scheduled for summer and fall. These are through several programs in the health department, and then we have shadowing for our primary care clinics, our staff going out to other departments and going through those. And I mentioned too, that Angie's talked before, the partnership with Duke University for that HEAL grant. As the budget, we still got 3 years on our workforce development budget, so that's what will be funding that internship coordinator proposal, and we're still working through that process. Human Resources, April start date, we had 3 employees, Davina Moore, Public Health Nurse 2, Inari Mondragon, Dental Assistant, and Karen Collins, a PA 4 in WIC Nutrition. Currently, offers are being made right now for Office Assistant 5 in Environmental Health, Social Worker 2 in Outreach, and a PA 4 in WIC. So through the end of April, we've had new hires, 31, 6 turnover, and 2 retirements. I mentioned, again, April 2025 Employee of the Month, Dion Dockery for Outreach. Very proud of Dion. That marks the 3rd month in a row we had a public health employee recognized as Employee of the Month. So congratulations, Dion. And then April presentations, or it should be April through yesterday. Greenville Rotary, I talked to them at the noon Rotary yesterday about public health programs. Talked to Pitt Partners for Health every month, and anytime anybody needs a presentation or anything like that, I'd be glad to either talk with them or have staff talk with them about specific programs. I'll mention we had a little bit of news earlier in the month about impox found in our wastewater. So the state called us and said they had found some positive mpox clade 1, which is a kind of a rare clade 1. We've only had 4 cases in the United States, and they detected it in our wastewater sewer shed on the 28th. And so they went back and tested on the 24th from a previous sample and found a higher concentration, and then none after that. So we thought it might have been a traveler. It's only been detected twice before in the wastewater system, two times in California. One was around the airport, and it was only one detection and nothing after. So they likely said that was a person that had flown in and probably flew out. And then the second detection, about a week later, they actually found a patient. So they said, well, they know this works at detecting that clade 1 mpox. At least one patient has been in that area. That's why it showed up. And so we looked at that and said, well, this could be the same situation here. Let's keep testing it. But we informed all the providers and the infection review committee at ECU to let them know to be on the lookout. And if anybody sees any patients, to make sure they refer to the health department. We had 2 negative samples, and then we tested on the 4th of April. And then that was still negative, and then the 7th April showed a positive. So we said, okay, so that triggered, and with the state's recommendation, a more public announcement of that say, hey, there's no patients here yet, no patients in North Carolina, no patients in Pitt County, and it might not be a Pitt County resident. It could be anybody that had flown in, used their university, used their hospital, used their airport, or just traveled through. And for some reason, we had that detection. We want to make sure it was disseminated, so we let everybody know about that. The state did a press release, and since then we've had no positive samples, so it's likely a traveler again. Department highlights, I want to mention the Certificate of Safety Achievement we received. This is our photo from last year's ceremony that Amanda Sparling was able to go to and receive our award, and this is the second year we've gotten a consecutive a gold award. We're one of 2 departments to get that. In Pitt County, this resulted in substantial reduction in injuries and illnesses and the promotion of safer working conditions in the year 2024. So congratulations. And then one thing I wanted to mention, this was brought to my attention today, the Eastern Healthcare Preparedness Coalition. I wanted to give an update. And Amanda, do you want to mention a few things about what you've learned about that so just the board can be aware?
I don't get to push the button, but you're probably like, Healthcare Coalition, what? So we had a quarterly meeting for the Eastern Healthcare Preparedness Coalition today, and that coalition's been around since 2002. It's integrated into the ECU health system back when it was University Health, Biden. It's been there a long time. If you know Chris Starbuck or any of his team, they're very helpful and they're very integrated into this stuff. So it was just the update they gave us today. Kimberly Clement from the Office of EMS came and kind of gave us, it sounded like no update, but an update. But essentially what we know right now is that they have not received a request for application for their grant for next year. Our program with PHP&R has received it. We've submitted it, so I think we're a little better off than them. But they, as of June 30th, they have no funding for that program. And you're probably like, what did they fund? So the Healthcare Preparedness Program funds all of their staff, as well as all the exercises, the materials they have. If you've ever heard of like the mobile disaster hospitals, any of those trailers, the SMAT teams, those are all funded by that grant. So ECU Health has graciously agreed to keep the staff that's there from that kind of July 1 date until September. But after that, they're really not sure because that's when they're supposed to vote, is the end of September. So conveniently, right through hurricane season. So what that means for us in public health is essentially they will evaluate their response capabilities on a case-to-case basis. I highly doubt that they would say, no, you can't respond during an emergency, especially if it was declared a state of emergency. All that stuff is reimbursable. But a focus that EHPC has, and they really kind of stressed this today, and a lot of folks spoke on it, was that, especially in this region and in North Carolina, they focused on enabling every county to be as prepared as possible. So yeah, they could buy all that stuff and keep it in their warehouse, but EHPC has done a very good job of kind of distributing these resources throughout their region. They have 29 counties. They spoke a lot about, Washington County, whose hospital does struggle a lot with even basic needs, but they've made sure that, these counties have what they need and they can have it with little to no cost at all. Just recently, we were going over our respiratory protection plan, making sure we had certain things for us in public health as well as EMS, and it turns out the coalition had actually gifted us some of the respiratory devices that we even needed. So that was just a really recent example of it. But I just wanted to kind of make everyone aware of that gap that is potentially coming in the funding like that. And really also focus that EHPC focuses a lot on information sharing and communication support. Matt McMahon, who works with them, was critical during the Helene response. The Viper radios that we utilize for EMS were one of the only things that worked out there. So he's supported by the grant as well. And what else was I going to say? Really just kind of bring it to everyone's attention that is something that is a potential barrier as we approach hurricane season, and that EHPC, if you hear anything about the HPP program or EHPC, just know that they're awesome, and we hope that we get to keep utilizing some of their resources and their partnerships and their exercises and stuff like that.
Can I ask a question? So if you get rid of EHPC and you get rid of FEMA, we're sort of going to be on our own here at each county, right? Is that that's the potential outcome? Is that?
Well, the coalition would still exist, but it wouldn't be the same level of involvement and.
If they don't have any funding, it's going to be hard to mobilize the SMAT, right? I mean,
Right,
that's
it
what
would
they
just be
do.
people talking. It would be a coalition of, what's your resource, what's this? It wouldn't have the same level of capabilities. They discussed a fee-for-service kind of model today. That is a possible option, but again, they don't really know what it'll turn into. There's talk of departments combining at the federal or the state level to provide different types of programs, but something's definitely going to change from what we have kind of heard. But yeah. Of course. This is mine. Yeah.
Thank you for that update. Again, it doesn't affect our budget, but it affects our community and our response. Absolutely. Another highlight, we attended the Eastern District North Carolina Public Health Association conference and took a group of folks down there in Elizabeth City. A lot of sessions on FAMI, which is our admin and billing sections, public health and nursing, emergency preparedness, health directors section had a lot of great things about Legionnaire's disease and a lot of current hot topics. And so glad we got to go attend that conference. And then the biggie for this month is the accreditation board voted last Friday to accredit Pitt County Health Department with honors. And so this is our group that went up there to accept the award. So congratulations everybody on all the hard work for that. And with that, I will say thanks and any questions you might have.
Are we going to have a party?
Yes, we're
Okay.
doing a big press release and hopefully some news stories about that. And we got our plaque and everything, so we are
Wonderful.
going to have a party for everything.
Congratulations, great job.
Yeah, I do have a question.
Yes, ma'am.
Not pertaining to your report, but I want to know, I received an email, and I didn't see it until yesterday, about a complaint. Do you know about that?
Is it about
It was about, I believe, a reporter being removed from
Yes.
the premises, and she complained about employees.
Yes, I forgot to mention that. Yes, absolutely. That was I think it was the last department head meeting which we had was March, very end of March. We were in the middle me and Andrew in the middle of a department head meeting with here in the EOC, and our front desk called and said a person was in our lobby with a cell phone camera filming patients and filming the lobby. And so immediately we said, we've heard of situations like this where they're called like First Amendment auditors come and take video inside and post that on the internet. And basically they try to see what they can see through the glass or in patients. So on the way there, we talked to the staff and they had moved some patients out. The person had been filming patients, asking people questions, filming, in one case, a child in a carrying case, getting the father very agitated, asking why they were there. And so the father got moved into the health ed conference room. By the time we got there, we talked to the person. We said, "Are you here for any service? Can we help you with anything like that?" And they said, "No, they're just here to film as their First Amendment right, this lobby. It's a public space." And we have said, the outside is a public space, the inside, especially of a lobby, a person's office, a military base, there's all types of government-funded agencies that aren't public spaces, that especially where people have an expectation of privacy, like walking up to the front desk and asking for an STD test or pregnancy test. And so that's what a lot of the people that have YouTube channels do, is they film this trying to make a confrontation and tried to get thrown out or something like that. So we were very respectful to the person. Law enforcement did come and they said, and asked them to leave for trespassing and creating that disturbance, basically with that patient and that father. So the person went outside, did not give their name. We gave our name, contact information, everything. They said they were named Betsy Ross, and they wouldn't give a title or anything like that. And they said they were going to stay there the rest of the day and film anybody coming and going. They wound up staying about another hour. So we didn't hear anything after about that until they contacted Matt, and I guess attached all the commissioners to it, that they were called the J-Town Press. And so we found them on a website, and you can see that they go to post offices and government buildings and have interactions with the police. And the intent is to get thrown out, which ups the views. And so it's not a normal, a situation where we have a reporter or something like that in the building. It's a situation where it's a citizen reporter doing a First Amendment audit, which most legal, there's not been actually a test case on it, but most have said that a lobby, especially of a health department, is not a public space that is for freedom of expression and freedom of the press. It's a separate space than would be something like a lobby or a parking lot outside. So that's what the guidance we went with, and asked that person to leave.
Well, we got the email asking how to make a formal, I guess,
Yeah, I sent the description, a long description, to Matt Gibson so he could inform the commissioners if they had any questions about that. But I don't know if he's going to submit a formal response to that complaint or anything.
I didn't see it until yesterday.
But yeah, I definitely wanted y'all to be aware of that. Thank you for bringing that up, because I was wondering if anything would come of that, if it was posted or something like that. So it's been a similar thing happened in, I think, Jones County and a few other counties around Jones. And one day a person came in with a ski mask and filming and everything, and it was a First Amendment auditor. So we knew that this had, I think in Alamance County they had a case like that. So this is the first one I'm aware of that we've had. But definitely this summer, or do a kind of more staff training just to be aware of when something like that happens, kind of what's the proper procedure. And I think when I've told our regional folks, and they're going to do some trainings at their health departments around it as well, just in case they get somebody like that.
Thank you, Wes.
All right.
Good, Commissioner. Okay, great. All right, last item on our agenda, approval of the minutes. Thank you, Lauren, for preparing the minutes. Very well done.
Motion?
I'm waiting. Awesome, thank you. All right, so it's been moved and seconded. All those in favor, please indicate by saying aye. Any opposed? Amazing. All right, I don't think I have to vote for adjourning our meeting, so unless there is any other comment for the good of the group, we are adjourned at 7:38 PM.